think a lot of well, I think it's trying to win having impact for isn't it? Really,
You?
yeah. No,
I didn't get one from bird.
I had no idea.
Yeah, well, right. So I wouldn't know.
No.
How to really listen to.
Yeah. Because I'm fond of it, and we're quite big in town.
I think it's 45 menit presentasi 45 menit
Also,
1.5 hours. Okay, good afternoon, everyone. I think we can start. And also good afternoon to those people joining from Zoom. So I think I'd like to start by acknowledging the traditional owners of the land where we meet today, the Nganul and Ngambri people, and pay my respects to the elders past and emerging. So for today, we are very grateful to have Dr. Giovanni van Empel, who is going to talk about his research with his co-authors, and Niha is also one of them here. Dr. Giovanni is a research fellow with the Department of Health Economics, Wellness and Society in NSEP ANU. So in terms of his research interest lies in the intersection between health economics and also labor economics. And I think his fascination also in the organizational features of the healthcare system, such as hospital competition and peer influence that affects healthcare delivery. So Gio is also having a medical degree. So you can ask all detailed questions later on in terms of JKN and also the utilization. So after 45 minutes of presentation, we will have about the same time for Q&A. So I think without further ado, let's just welcome Gio.
Yeah. Okay, so thank you, Marika, for the invitation. It's been a pleasure to be here today in this beautiful forum. I've always find it very stimulating, and have seen the legends that are here today. And so I'm looking forward to the discussion. And so today's presentation is a joint work with Niha, which is here. She's my brilliant student, just started the PhD last year, about 1+ years. So this is part of her PhD project. And just to acknowledge that her PhD is funded by the LPDP Doctoral Scholarship before we start. The sense of the paper that I'm going to present here, essentially, that we're interested in the broader questions and how the public and private health insurance system could actually work. And specifically, we asked the question whether the expansion of the public health insurance program, which we know in the form of JKN4 in 2014, is actually what is the impact of that on the private health insurance ownership. Now, the motivation I will explain to you a bit more, discuss a bit later, but you will hopefully see it clear how it relates to the broader policy context. So I'll start with the Indonesia's overall move towards the universal health coverage. So this is not something that is recently started. It has been pretty much accelerated after the 1998 financial crisis, which then proliferates into some form of financial protection for the poor in form of ASCAS in 2004. But the ongoing talks has been pretty much how we can provide a financial safety net for all people of Indonesia. However, prior to the early 2000s, most health insurance only covered those who are working in formal sectors, government officials and military personnel or policemen. And it has been known that the health insurance schemes is very segmented. And so in 2014, the journey finally culminates. Basically, Indonesia decided that we are going to have this scheme which then everyone can join and be part of if not one of the largest single payer systems in the world. So the idea is that the program will pretty much be provide an effective safety net for the wider population, not only those who are working in the formal workers or those who are not are poor people. And most importantly is that the reform is not only shaping the way that the health system sort of works after 2014, but it also changes in how the health insurance system landscape. So in this slide, I'm just going to show you how the JCAN has achieved so much. After the rollout in 2014, the JCAN expanded rapidly in terms of their coverage. So if you look at this graph here, so right after its inception in January 2014, the number of population starts growing really fast. Whereas before it's only limited to some form of workers. And we know that the evidence, there's a whole lot of prior studies that looked at the impacts of the JCAN on several important outcomes, such as maternal healthcare utilization, and also has seen to improve the infant mortality. And there are also studies that looked at the impacts on various subgroups. There's a nice paper recently that looked at the impacts of JCAN on people with disabilities that shows that there's a higher use for people with disabilities and lessen the catastrophic health expenditure among this group. In a joint work with Arif, who was also here, we also look at the expansion and how this impact the informal sector workers. But there are challenges remain in this program, which one of them is widely known is that lower middle income groups, particularly the informal sector workers, is harder to enroll. And there is also an issue of that only high risk individuals that are eager to join the scheme, so which is typically known as the adverse selection in economics terms. Now, one of the other tension that is concerning recently is the sorry, yes, you can.
Can I interrupt?
Yeah.
I mean, that graph is really important. I'm just trying to understand it.
Yeah.
Maybe you'll talk about it later in more detail.
Yeah. So this. So yeah, you can.
I was going to say. So, do we understand correctly that the purple or the mauve, whatever it is?
Yeah.
They get their health insurance premium paid for by the government.
Correct.
Is that right?
Yes. So this the purple. So this is from a paper by Rina Agustina in UI and other co-authors, and it's published in the Lancet in 2019. So the purple graph shows the proportion or the of people who are subsidized, who are paid by the government in terms of their premium.
Fully paid.
Fully paid, yeah. So they don't have to do it. So this group here was just a bit of a sidetrack here, but this group was those people who are covered by the ASCA scheme before Jamkasmas in 2009. So it didn't change, but it only expanded once the JCAN sort of rules.
Okay,
Yes.
thanks. And then, sorry, just to quickly, and then the brown or I'm a bit colourblind, whatever colour, brown or orange.
Yeah.
So they're the ones who pay themselves.
Correct. That is the formal sector workers or paid by the employers.
Yeah.
And the green bar here is the share or proportion of those who are informal workers and non-salaried, which is the majority of the Indonesian economy. But here it's only 35%. 35 millions.
And they're also paid for by the government?
No, they have to pay themselves.
I see.
Yeah.
If they're above the
Yes.
threshold.
So if they're not eligible to get ASCAs or like the subsidy from the government, then they will have to pay their own premium. So that's where the trouble is to enroll them.
Okay. Yeah.
Because in a society where it's not accustomed to insurance system, it's hard to understand the benefits of one.
Terima kasih.
Yeah. Also, feel free to, if you have clarification questions along the line, I'll be happy to, rather than I'm, continue to confuse you. So, okay, coming back to one of the other concern that is pretty much related, or the core of this paper, is that the concerns over the JKN financial sustainability. So pretty much the JKN scheme has faced financial strain over time since its inception. So you can see this graph here, and it's just showing you the net revenue, which is the gap between how much the JKN got from the government support, and also the premium that were collected or paid by the people, and the amount of how much they have to pay to the hospital, to the hospitals, also to the primary care clinics. Right? You can see that from the start, they've only incurred losses, meaning there's an ongoing deficit, and this is showing you how the cumulative net revenue or cumulative net deficit over time. So this one is in trillion rupiah, so trillion. So it's not much compared to like the overall APBN which we have, but there is this concern that if we don't do anything about this might not be viable for long term. Now, yes.
Sorry, Giovanni.
Yeah.
Are there any data beyond 2019?
Yes. So the reason I only put until 2019 is that because the data that we use only covers to 2019. So in 2020, which COVID hits up until 2022, is actually making more money. So not deficit at all. But that's partly because less people gone to the hospitals. There was mobility restrictions, and hospitals are basically a war zone for treating COVID patients. So they are delaying the treatments, the surgeries, yeah. But the recent estimate is they incur losses, which is in 2015 it's around 15 trillion. But every time the government decided to bail out the situation. So the experts have been saying that this was caused by numerous factors. One is there was basically starting with a low premium. The government can only pay so much. But there's also another concern that is coming from an inefficient or ineffective primary care. So the gatekeeping system is not working as effective as we expect them to be. And so recently, and this has been said, if you look at there's been interest of the current policymakers to actually encourage a mixed health insurance system, which is essentially trying to encourage more use or more share of private health insurance market. Now, if you look at the Australia, which I suppose recent estimates suggest that half of the Australian population has some form of private health insurance. It's a big player in the Australian health system. It's not necessarily the case in the UK, where it only has like 10 to 11% of the overall system. So in Indonesia, we only have probably closer to what the UK has. It's never been a big player in the Indonesian health system. But the reason there's a growing interest of how to encourage this mixed system is that in the idea or in the hope that such coexistence between the private health insurance and the public health insurance would alleviate some of the pressure on the public spending. But the idea pretty much hinges on the demand for the private health insurance after the JKN rollout, which is what we are trying to look at. Because if the JKN sort of crowds out the private health insurance, it would be hard for this idea to encourage a mixed system to be attainable. So prevailing expectation is that there is a coexistence between private health insurance and JKN. So this was a statement by the current Minister of Health at the time when he was still the President Director of Bank Mandiri. And Bank Mandiri has a portfolio, one of the portfolio in their business to offer private health insurance. And the statement was that apparently there was a confidence that even after the JKN rollout, the PHI market is still projected to grow by that whatever number that he said at the time. So it just signifies how the not only the figure who set it at the time, and especially in the current position that he's at, but there is there's an interest about how to make this coexistence between JKN and private health insurance system. So we will see that whether that's the case here. So what this paper is about is that what we asked is that the main question that we asked is that the DJKN crowd out the private health insurance ownership. We also look at later on, which we will see the subsequent use of healthcare utilization. So why it matters is that if the crowd out of the JKN is massive, that would make the idea of the interest to grow to encourage the mixed health insurance system would be harder. So that speaks to the importance of for the future design of how the public and the private health insurance system in the Indonesia could achieve. So how we approach the question? So we think that the way that we conceptualize the problem is that we think we conceptualize the JKN rollout as a price shock for health insurance, and this is the reason is that before the JKN rollout, which we'll see later, I'll discuss a bit more, is that it effectively lowers the price to get an insurance for people or for households to get the healthcare use in the healthcare provider. And so you're going to use a difference in difference design here, and also on top of the event study design around the 2014 rollout of JKN. Yes, Pavli.
Have you mentioned about the size of this private health insurance?
Yes, we'll. I haven't mentioned it specifically, but we'll after this slide. There's a specific slide on the PHF market. It is small. It is not massive. But what I can say is that the magnitude is quite bigger. If you're already starting from a low base, whatever magnitude that we see from the estimate, it will account for a large market share. So the idea is that there are households that are pretty much insulated from the price shock, meaning that this is the control group that we're thinking of. So the control group that we're thinking of is that those people who are in the first to the fourth deciles are pretty much insulated from the price shock. The reason is that because this is one of the main proxy criteria for the government to decide whether they're eligible or not to get the subsidy from the government. Right? So they don't have to pay from their own pocket to get the health insurance. But that's not necessarily the case for the upper deciles, which is they're not necessarily eligible to get the subsidy from the government, and so this is pretty much groups that experience a larger shock.
What about the 9th and 10th deciles?
The 9th and 10th decile we have that as a robustness check. So we have that, but the majority of those who actually have the private health insurance is actually coming from that 2 deciles.
Sorry, let me clarify.
Yeah.
The numbering of the deciles is first to fourth. Is that the top 4 deciles?
No,
the
bottom 4.
They're the poorest.
Yeah.
So you're not interested in the richest group.
Yeah. So we went to because the top is very different to the control, but in later analysis we have that as a robustness check to see how big is the difference between the estimates between the base model and with that.
Yes. After you, Andy.
Yeah.
So that means the bottom, the people who get the subsidy, it's like a voucher, is it? They can take it to a private health insurer and say, "Here's my premium paid for by the government." Is that so?
They are not so. This is not necessarily restricting them from buying private health insurance.
Okay.
Right. But so this group is less likely to buy private health insurance because of the financial constraint that they have in the household. Right. So this is a relative exposure. We don't have a pure control group here. which we can say that that this group is, is not effectively not exposed whatsoever by the JKN rollout. Thanks. So what we find is that the JKN rollout apparently decreases the likelihood to own private health insurance by 1 percentage points. The effect size is huge here, so it corresponds to a 30% relative to the pre-treatment mean of the treatment group. We also find that the JKN rollout increases healthcare utilization among groups who are more exposed to the price shock, and that is consistent with the other literature that have been done over the years on the impacts of JKN overall. What we also find is that there's no indication of improvement in health outcome. So that's also an interesting.
That's a big question.
Okay,
So
so
just on that
yeah.
last point.
Yeah.
That's almost impossible to believe, isn't it? It's it goes against common sense. I guess you're going to expand on that, are you?
Yeah, yes. So this is with I would like to actually put a star on top of that, because the health outcome in the Sustanas data is pretty much not a non-objective measure of health outcome. So it just asks, it's a self-reported measures whether how you feel about whether you can still do daily activity towards it. So it's very different to an objective health outcome, such as, what is your readmission after you went through to the hospital to get a treatment, for instance. That is not possible to do with the Sustanas data, in which we only have that. But I'm open to suggestions if you have, if any one of you has suggestions on how to perhaps have a better idea of how to do the impacts on the health outcome.
But you look at things like infant mortality, wouldn't you?
So that is infant mortality. With Sustanas data, you mean?
With whatever.
With whatever data.
But I mean, that's
Yeah.
the kind of measure for the whole population.
Yeah.
Available.
Yeah. No, it's a great suggestion. The only thing that we need to think of is that how can we link that outcome to the definition of the treatment and the control group. So we need some form of data in which we know that that household experienced an infant mortality or not, and we know the expenditure of that household, right? In order to track the trends over time.
I was just thinking more in terms of the program as a whole. And
okay.
About the different deciles, but
Yeah.
say, okay, we've introduced the program in 2014.
Right.
12 years later, is there any
Right.
measurable impact on demographic demographic variables?
Yeah. So that one in infant mortality has been done before in one of the paper by the researchers at University of York and UE. So they look at the infant mortality and they find that it is an improvement from the rollout. I don't understand the whole detail of that paper, but I'll look into that a bit more and how we can. But it's a good suggestion to look at the other demographics outcome that we can think of.
I mean, I suppose, Giovanni, what you'd look for is, has there been a structural break in the trends in infant mortality since 2014?
Right.
That's
yes.
You could do that, I think. I'm
Yeah.
a statistician.
So we need No, we can do that. We will need a different data set for that. Yes. Yeah. But
So I guess if the unit is not individual, if the unit is at this stage, then you have to also administer
yes,
number.
exactly. Yeah.
Is available. Yeah.
That one we can link
number of case of infection disease.
Yeah.
Which is
Yeah. So that one we could do with PODES, I think, and then link that. PODES has that data. They ask how much, like the infant mortality in that DESA level, and also the infectious disease in that DESA level as well. So yeah, thank you for that, Susan. We'll definitely have to think about that. Okay, so this is just the contribution that we think of. There's 3 points here. So we extend the public and the private insurance crowd literature, which has mostly done in the developed economies. The second strand of literature we think of as this paper can contribute is that it adds to the evidence on the consequences of JK and rollout. But we extend that beyond just the healthcare utilization and health outcomes by looking at how the JKN affects private health insurance demand and provider use. So there's a nice paper by Darius Erlangga who used the IFL study to look at the impact of JKN on the healthcare utilization, because it's only short-term effect of that because the last wave of IFLS was captured in 2014, 2015. So extended by looking at the bit longer term by having more data points. Okay, now, so this was one of the main interests. So just try to show you to illustrate how big is the PHI market in Indonesia. So it is modest in terms of size. World Bank estimates in 2021 that the market size for the private health insurance only 8%, covering 8% of the population. It accounts for 3% of the total health expenditure. It is a very highly fragmented market, so there are hundreds of different health insurance schemes that are available for individuals to buy. But the idea is that because of the fact that the out-of-pocket spending, it still accounts for a third of the total health expenditure, is that there's a confidence or there's a expectation that there is still room for growth to grow this market. So in some the private health insurance is a small base, and we'll after this I'll show you why the JKN might crowd out the private health insurance ownership. Right. So the question is that how can the private health insurance sort of coexist with the JKN? Is it a close substitute, or is it has to be a complementary to the existing JKNs?
Do you have any idea for this private health insurance? Usually it's more like coming from the formal sector employers, or is it like as an individual, then you opt for having private and then you pay on not by your portfolio?
Yeah, so it's a good question. I think you could do either way. So like you could buy your own private insurance without your employer pays that for you. But there are typically there are agreements between certain employers with an existing health insurance company, for instance. So they could provide discounts and more benefits, for instance, relative to others.
Which one is more prevalent? Like in the case of Indonesia,
That-
I think that's my interest.
Yeah, though that we don't know yet. We need to look at the OJK statistics on the so they compiled annually this type of reports that looked at how much the premium are being paid for this specific private health insurance and how big is the size of the customers or beneficiaries. But we'll have a look at that, whether it's coming from mainly from those who are working in formal sectors or not.
Chief.
Yeah. Yes, you can.
Yeah, so in the SOSMS data set, they ask different questions whether you have private or from employees or you have private from your own. So the one that we look here is only those who have private for their own. So we exclude those who employ insurance. That's right.
Okay.
Yeah.
Thank you for that, Nia, for clarification. So it's good to have the one who is leading the study here in the room as well and to help me out. And it's a tough question.
Yeah, and so the
Yes.
8% is that one, or 8% is the total that including those who is with our company?
No, it's only who pay by themselves.
And that is the 8%.
So 8% is overall though.
Overall,
So yes,
so-
it's not from Susanna.
So then how many percent is actually paying from our packet? How many percent of the population is actually paying from our packet? Must be much smaller than that.
Yes.
Yeah,
Yes.
it's around 4%.
4%.
Yeah. Very small. Okay. I'll continue okay, so this hinges on the basic substitution mechanism on why the JKN might crowd out the private health insurance market. So if we compare across different features, you can see that the JKN premium is much cheaper than the average private health insurance premium. And the benefits are comprehensive. So the JKN is probably one of the most generous health insurance scheme in the world. Much more than the Australian Medicare version, where Medicare is only providing you basic services and emergency services, and on top of that, you need to have a private health insurance. Whereas JKN is pretty much comprehensive. So there's no limit to how much they are willing to pay for one episode of care. That's not necessarily the case for private health insurance, whereas there is a strict limit in how much you can spend on a given episode of care. In terms of the benefits, the private health insurance is also limited. It depends on it is risk adjusted premium. So it depends on like your past history of illnesses, your age, your risk profiles, and things like that. But that's not the case for the JKN. In terms of the hospitals, the private insurance typically can be used in all types of hospitals, but the JKN is relatively less limited than the private insurance because it is mandated for the public hospitals to be part of the JKN networks, but for private, it depends on their willingness to be part of it. So there is a less limitation. So it's hard to find how much is the individual premium. We've been trying to find the price, but this is one of the result that we have here. So in 2013, that the average individual premium can cost around 100 to 600 Australian dollars a year. So that corresponds to 1.1 million to 6 million rupiah annually. And that corresponds to around 13 to 7% of the yearly average expenditure. So it is
On what?
Huh?
Average expenditure on what?
On the overall expenditure on the household expenditure. Yeah, total expenditure of the household. Yeah. Of the average expenditure per capita. So every this takes into account of all expenditure.
All consumption expenditure.
Yeah, so this estimate comes from the expenditure that is calculated from the Susanas data, which accounts for consumption as well, I suppose.
Misses big items.
Yes, so there's the caveat on this. I don't know the direction of that, whether this is an underestimation or an overestimation, but it's not by no means it's not perfect, but just to show you that this amount translates to this the proportion of the average expenditure. But in 2023, this is one example that I got from a certain health insurance scheme. It's a comprehensive care plan, so the average premium range from 12 to 18 million rupiah a year. So that's not cheap for the majority of households in Europe.
Is it household or individual?
No, sorry, this is individual, but as the household make decision, so it is individual, yeah.
I just wonder, it is true that many of the people that are taking private health insurance mainly for availability of general checkup. So
Right.
JKN actually do not have this facility.
Yes. So like the preventions of preventative care in the private health insurance, is something that is interesting for a lot of people. Which JKN is pretty limited on that. It is good for curative expenses, but okay. So with that, I'll segue to the empirical intuition that it seems like there's a whole lot of different reasons why the JCAN might crowd out private health insurance, we just look at the table that we discussed in the previous slide. It seems like the JCAN is arguably a superior option to any kind of private health insurance on top of maybe different schemes here and there. So what we think of initially that the JCAN role as a price shock, which means that it reduces the effective price of insurance for some households. We think that the higher expenditure households face a larger change in the insurance choice set after JKN, because that option now appears, and it provides great benefits. When they compare to a different range of features, it seems like it is a more advantageous over a different set of criteria. The control group that we're thinking of where we compare is that the lower expenditure households is less likely to be exposed to the or affected by the JKN rollout, because they've been pretty much covered to or eligible for the pro-poor scheme that existed prior to JKN in the form of Jampesmas or ASKAS in 2004, and in 2014. They just changed to a different name, which is the Penerima Bantuan Iuran, but essentially is the same criteria. Although there's a change recently, but for the sake of simplicity, that they are relatively similar across time. So formally, so that's the empirical intuition. This is just the formal way we approach this, is that we're going to use a two-way fixed effects difference in difference design, in which we, after we condition on a set of different variables, including province area level, area-specific influence, year-specific influence, and also province-specific linear trends, that the beta here will be informative on how the changes that is induced by the JKN rollout on the private health insurance ownership. Now, the identification depends on the idea that the trends should be similar. So the group that I've just mentioned is not experiencing a differential trend over time. So the way we're going to assess that formally is that we're going to use an event study to look at the trends between these two groups, and also empirically assess the dynamic effects over time. We cluster this specification at the kabupaten level, and yes, so data and sample. This is coming from just primarily Susanna's data. It is a repeated cross-sectional data. It is a nationally representative survey which covers various different characteristics from 2009-2018 waves that we use here. We have around 1.4 million households in our sample. So the analysis is strictly at the household level. We don't look at the individual level. We look at various outcomes that are captured in the Susanna's data, where they have the types of insurance and also whether they use healthcare or not at these two different levels. So this belongs to Pak Budi's question earlier, that we look at this in proportion that the private health insurance is around 6% overall in the sample. So that is close to what the World Bank has estimated. But if we compare that to the control and treatment groups, there's a markedly different. Some people in the control group has some form of private health insurance, but that's very different when we look at the treatment groups. In terms of utilization, it is arguably similar. When we look at the primary care and the secondary care is lower for the control group. We know that the base levels is different here, but that's not necessarily a concern for our identification, because I've just mentioned that we're looking at the trends, the changes in the trends after the rollout of JPN in 2014. Yes.
Just in the treatment group,
yeah,
it's not 1% of the people is actually having a private health.
Yes,
So even in the treatment group, it is very small.
It is very small. So we're looking at a very specific, like very small portion of people here, because the baseline is already very small. So that's one of the reasons why the magnitude that we I just mentioned in the previous slide, that the effect size is large, even though the estimate is low, like 0.4 percentage points, but because it's already coming from a low base levels, it corresponds to 30% less likely to have a private health insurance. So that is huge in terms of like the impact on the market share after the rollout of the JKN, right? Yes, Val.
Sorry, Hugh, but what's the, my ignorance, what's the difference between primary and secondary care in this definition?
So primary care is if you go to clinic
Mhm.
or puskesmas, for
Mhm.
instance, or GP clinics. So that's considered as a primary.
And secondary is hospital.
Secondary is hospital. Yes.
So the numbers in those rows are proportions of people actually getting secondary care, getting
Correct.
primary care, and having private health insurance.
Yes, that's right. So this 11% of them, 7% for the secondary care, a third or 33% of the people there. So this one is less than 1% even.
Just quick question, why for the treatment is less than 1%, control is less than 1%, but for all is 6%? So the all, is it also, does it include those who have the private health insurance paid by the employers?
So the all accounts for also the 9th and the 10th decile.
Okay.
Yes, which is not part of the treatment or the control. Yes. So that you can see that the major proportion of those who actually owns the private health insurance is coming from the top 2 deciles of the expenditure.
Yeah, it's actually like almost 90% of private. So, you know, for the private sector, doesn't really matter.
Mm-hmm.
Given this statement, you know, the people in that 5 deciles actually do not take it because
Yeah. The market share is that,
yeah,
right?
market share is
Right.
those people.
Right.
Among those people, it's only 5% of them are having the private health.
Yes.
So for them, expanding the market, concentrating on the 9 and 10 decile is what they want to do.
Yes, yeah, and that's a good point to motivate that the fact that it's still operating, right? The private insurance is still operating, and it seems like they're very segmented and they're looking at that specific target. But even if we include that in the analysis, there's also they also experience a decrease in that. Although I would say that I don't know if the magnitude, I don't think I've calculated them, but I think it's smaller than if we look at this. Yeah. But you're right in that sense. I think that's a great point to have whether we should actually use or include that 9th and 10th deciles as the main, because that's where the majority of the people that have the insurance. Okay. I'm just gonna tap that down. Okay. Right. What are we getting there? Okay. So this is just formally showing you the results of the main 3 outcomes that we have. This is just pulling everything into the main 2-way fixed effects model. And as you can see there, that if we look at the first column there, PHI private health insurance ownership decreased by 0.4 percentage points. And if we look at the primary care utilization, it's actually decreased after the JKN rollout. But we are seeing an increase in the hospital care utilization. So these 2 results it's a little bit puzzling for us, because we kind of expected that the primary care utilization is also to be increased, but we might have some idea why that happened, in which I'll show you a bit more as we progress. So this is the event study on the private health insurance ownership. So over time, if we look at prior to 2014, that the trends between these two groups are actually parallel. So that's great for our identification. And then once the JKN rollouts, we see that the decrease close to 0.4 percentage points, and it is persistent when we consider up until 2018. Yes.
Is it Jakarta also in the sample?
Yes.
Because in our other paper that we found the positive spillover, right?
Yes.
There are a lot of the JKN. So probably if you drop out Jakarta, the magnitude will be much larger than.
Right. That's a good point. We have a.
Because Jakarta in 2016, they rolled out free health insurance for everyone.
Yeah.
So
if we exclude that,
it will be large.
maybe it'll be larger after 2016 for some. Then you probably see that a little bit increase after 2016, right? Like this is where Jakarta has that free program, so it doesn't goes down, but it actually increases. So that might explain a bit of that increase. Yeah, we will have to check. Okay. If we look at the primary care utilization, it is 1.5 percentage points less likely to use primary care. The effect size is modest, only 5%, relative to the treatment mean. Now, if we look at the hospital care utilization, the effect size is positive, close to 0.8 percentage points. The effect size is slightly bigger than the close in the primary care. And when we think about the hospital care utilization, it includes both outpatient and inpatient services. There's a bit of a interesting coefficient there in 2010, which we're going to try to do a bit more on that. Maybe look at the specification, but it seems like overall the results is showing on an increasing pattern. Now, if we, I don't know, do you have anything?
5 more minutes.
Okay. I'll try to, is this important or? Okay, just gonna skip this around. So if we look at the different types of care, we see that the primary care is decreasing in terms of their outpatient care. And then if we decompose the secondary care or hospital care based on whether they go to outpatient and inpatient, it is somewhat consistent. The results is showing that the utilization increases. So it seems like it is not a definitive, but it suggests that there are people who are bypassing the primary care to go directly to the hospital to get the outpatient care. Now, is this entirely possible? There is a bit of a tension here, pretty much because the JKN system has introduced the gatekeeping system. So if one wants to go to the hospital, they would have to go to the primary care. So that tension is something that we have to reconcile in the work. But there are also evidence that people can go to the primary care, and this is anecdotal based on the own practice as well, and that people goes to the primary care only to get the referral letter from the primary care. So they want to go directly to the to see the specialist in the hospital, and so they're not getting treated whatsoever in the primary care. So that's a plausibility there, but we need to work more on that. In terms of the choice of providers, it seems like if we look at the secondary care here, it seems that both use in the public hospitals and private hospitals increase. So this is also interesting because, as mentioned earlier, that the private hospitals are pretty much a selection of hospitals that wants to be part of the JKN. Now, the discussion or the debates around that time is that the JKN tariff is actually pretty low, and so it actually prevents a whole lot of different private hospitals to actually join to be part of the JKN network. Now we look at the whether the use of private hospitals increases right after 2014 rollout, and we see that it only increases observed down the road. Now, in our interpretation is that this might suggest that the private hospitals actually joined later after a few years of the JKN implementation, but only suggested. This is not definitely. Okay. So one paper that looked at this is that many private providers avoid JKN because of the low tariffs. So they can't cope with the amount of how much they need to pay the doctors and the operating costs relative to what the government tariff is. So only 60% of private hospitals actually join. And I recently have and there are also hospitals that opt out from JKN in recent years. But also, we are not exclusively saying that they only join later, but it could also be that the different groups of people have perceived differently towards the quality of care in these two types of hospitals. So that might be caused by that as well. Okay, so yeah, to sum up, it seems like our results sort of indicate that the JKN rollout actually crowd out the private health insurance ownership, and it suggests that in our interpretation, it suggests that the JKN is actually a close substitute option to rather than a complement, and so they don't mind dropping out from the private health insurance scheme. We don't find, these are not results that we showed, but we don't find differential effects across urban and rurality. We also don't find any difference if we consider only in Java or non-Java islands. So it seems pretty consistent over different subgroups. So different challenges in growing PHA markets, which so Ross, I saw the paper that there's also that concern there whether a compulsory social insurance could actually changes how the existing private health insurance market. It is very segmented historically, and so what happened is that if it is very segmented, then you can only risk pool as much, right? So and that means you cannot provide an affordable premium to an average individual in Indonesia. So I think the greater reliance on the public system raises questions, but our results speaks to the debate whether this is the introduction or the encouragement of a future design of mixed systems can actually be attainable or not. Okay, so thank you.
We will take 3 questions. First, do we have a question from online? So maybe we take 2 from the room, and then after that, 1 from online. Any questions, Arif?
If you do the like particular business check rather than using first until for decide using the indicator of those who has the calculated social.
Yeah.
But it's much more accurate.
We haven't done that, but yes,
Okay, yeah.
yes, it's a good suggestion. Yes, Mo.
Thank you very much for the presentation, and yes, nice one. So number 1, probably this is not that important, but 2015 there is a big gasoline price increase. Jokowi reduced the gasoline price in January every year. It is very good. That is another shock that you need to take into account. The surprising result is the regional. The regional differentiate is actually not that big. I just wonder why this was, because the private health insurance, I believe, in outside Java has been very small, and so I thought that this effect is the Java effect, but turn out it is not the case. And the third aspect, I think you need to check whether the qualifying for subsidy, qualification for subsidy is actually equal to the expenditure. of Susanat. What is that mean is that
Yep.
people could behave in such that what they're reporting to make them qualify to receive a subsidy, while in Susanas they're still in the same quanta. Yeah. So and particularly those working in the government can do that because they can just submit their government slip and not under income.
Yeah.
When they know that with a certain cut-off you get a subsidy, and people do behave there. Yeah, and I think some region, so for example Jakarta, most of them probably sorry, I'll forget. Let's stop.
Yeah, thanks for that, Pabri. Do you have an idea of like how big is the sort of like the gaming of the strategic behavior of the people that would, you know,
Well,
selectively.
I don't know, but I used to work in PPT and
Yeah.
a lot of PPT people is doing that.
Right. Okay.
Yeah, but
Yeah.
because then, yeah, and their expenditure is a survey expenditure.
Yeah. So we probably could do something along the line of like whether they actually receive Kartu Perlindungan Sosial, for instance, because that would, if they said that they this is the amount of expenses that they have, but then they got the Kartu Perlindungan Sosial, for instance, that could indicates that there might be some, and how big is that growth? So we could try to do that, for instance.
I think after this we'll go to online, but I think if I
Yeah.
may just add the comments
Yes.
on that. I think for Niha and Gio, like try to think about for your treatment and control. At the end of the day, for the PB IJKN, there's always inclusion and exclusion error.
Yeah.
So how do you interpret it in terms of your identifying strategy? Because it's always there.
Yeah.
And then I think, but how before you just go to the online question.
We have questions from Darendra Wardana.
Yeah.
He asked, thanks for the presentations. I would like to hear from Giovanni about this seemingly popular statement. The fact that JKN provides comprehensive benefits, especially for catastrophic illness, makes it superior of PHI. Yet another fact that JKN is not so convenient in terms of access and quality of care creates some niche to PHI markets due to this sort of inferiority.
Yeah. So clearly that is a very well-grounded comments. That is not superior across different areas, because then if you go through access, if you want to access the care with JKN, you have to go through a long waiting list, for instance, or like waiting times is also a major disadvantage of that. I think that it's something that we would like to sort of explore, but we don't have the data in which we can say the preference of the people more. So based on this criteria, just looking by the price on paper, it seems like it's much affordable option relative to any existing average. But that doesn't preclude one from having two insurance, right? So you could have the JKN as well on top of getting a different private life insurance, which some people can use that to bypass the long waiting list as well. So
Can I add some? Yeah. So yeah, actually in the Susanat data sets, in the latest data sets, like 2018 upwards, there are questions about if you have JKN, do you use that to go to the healthcare services? But prior to that, there's no question of that. And the thing is, until 2023, the latest data, up to 30% of people who have JKN did not use the JKN card to go to the healthcare utilization. So that means, in terms of that question, is it true that there is a lack of trust from people of using JKN? But we cannot run the analysis because the prior data sets have no such question. So yeah.
yeah, well,
So thanks very much, Giovanni and Niha. Really interesting and important. So I guess I want to ask a question, which is maybe another paper that links to yours.
Okay.
So if you're thinking about the design of the Indonesian health insurance system, is this the way you would actually design it?
Right.
So maybe another paper, but it seems to me it links very closely to what you're saying, and your paper has lots to say about it.
Yeah.
So clearly, on equity grounds, you're getting more people insured, which is a good thing.
Yeah.
I guess so. That's the starting point. On efficiency grounds, what's your judgment? Is it the most efficient way to run a health scheme? And where's it heading? Is it heading towards? You mentioned the UK, the original NHS. Is it heading that way?
Right.
Is it heading more towards the US system where it's predominantly
Market-based.
private?
Right.
Or is it an Australian system where the Medicare provides basic and you can top up with your own private insurance?
Yeah.
So that's sort of general question. I'm
Yeah.
wondering, I mean, for example, you said doctors are only 14% in JKN, yeah?
That one is the
And that's telling you that doctors don't want to be
right.
in the system,
Yeah.
because I guess it's because they think they can earn a lot more outside it. So it's a JKN in a sense, basically structurally underfunded,
Right.
and therefore it will only ever be able to do basic stuff.
Yeah.
And one final point, relevant to your own experience, what about the supply side? This is all demand side,
Right.
isn't it? So is the supply side, are there investments in the supply side which are going to be commensurate with the increase in demand?
This is a very important question, and it's very hard to answer
Yeah,
that. But,
maybe it's another paper,
no,
but I'm just
but
curious.
it's a very important debate around it, because I think the design is something that is let's say the discussion around the best way to design it is it's still under discussed, I'd say, and so it's a very important timing, and also it's a policy that is affecting a lot of people. And I think to answer to you, so I think the tension that sort of like trickles me personally about of doing this paper is that there's an interest, even with the current government, for instance, current Ministry of Health, that there has been numerous statements from the minister, for instance, like, oh, the JKN can only should only treat the poor people and not the general population, and the rich people has to have private health insurance. But it's never clear to me, because it is never clarified of who should get it and who should not get it, because that has a very big implication about the design, right? And so if you want to like from quick impression, it seems like this could create a two-tiered system, which pretty much a whole different public system and a whole different private system, which can exacerbate inequity and inequality in terms of the health outcome. Because if there's also a big literature on like a cream skimming behavior of the providers that tries to funnel the patients towards the private and not to the public sectors. So that creates another tension. That is an Australian setting actually. So I think I can't answer properly, but it is a very interesting point, and I think that needs to be keep discussing about it. But yeah.
And the supply side?
Yes, for the supply side. So my understanding is that the number of private hospitals that are being built across, even after the JKN implementation, is still high. So it doesn't prevent them from actually building more private hospitals across different areas of it. So that is an interesting fact, but clearly it seems like the JKN is underfunded. So if you look at the amount of premiums from the start up until now, it doesn't catch up to the just general inflation. So it only revised after a few years, and it has to go through a political process with the DPR, for instance, and that creates a different kind of complexity as well. So that hasn't been catch up to that. So what is I guess what is concerning is that the current situation of underfunding is that it creates tension between the providers, so my friends and my colleagues that are giving treatments to the patients, and because they only can do as much to provide a certain treatments to the patients. And so that is certainly a concerning situation. Yeah.
Thanks.
Before going to Pak Joe, for this one, we'll have two questions from online.
Yeah.
One by one.
Questions from Grace. Great work, even with limited Susanna's data framework. I just wonder how out-of-pocket is considered here as a confounder, considering the JKN user might not use private insurance but choose OOP, or even the one with private insurance still use additional OOP.
So, right, we haven't thought about the out-of-pocket being a confounder for the behavior. I think that is something that could explain why the dropping out from the private health insurance. Because if you think about the amount of out-of-pocket that one has to pay for a private health insurance premium, that the expectation is that JKN rollout would decrease the out-of-pocket, right? So we haven't done that partly because the SUSANAS hasn't allowed us to do so. It only allows us to use 2018 data and not the other ways. But that's something that we are thinking about, and thanks for the suggestion.
Questions from Yogi Vidyatama.
Yeah.
How much employer decision making in the take-up of PHI may affect the result, or all decisions will be from household?
Ooh, that's a good question. Yeah, don't. What we can look at perhaps, yeah, I don't know I don't know the answer to that specifically, but I think if we can come up with some form of different subgroups in the data that looked at whether the private health insurance is coming from the employer or not, then we might have a say about that along the way. But at this point, we don't know the answer to that. But thank you for giving the consideration of that.
Yeah, I think for the next round, we'll take two questions from the room and then one from online. Pak Joe.
I'm sorry, I withdraw because it's the same question as asked.
Oh, okay.
Let's move on.
Great minds think alike.
So following Hal on supervisor, I think one of the important issue is whether JKN improve health services quality, isn't it?
Yeah.
Yeah. So, and one anecdote that we received when we travel to the region is that the biggest impact on JKN is actually on the private health services, which is the private hospital. Because private hospitals suddenly do not have much patient.
Right.
So they have to, because their price is higher and everybody is going.
Yeah.
And so they cannot actually, so that's why I was surprised that the private health hospital is actually increasing,
Right.
because many of them has been closed down.
Yeah.
Or they actually lower the quality. Yeah, they close down, or they lower the quality, or they increase very high. So just take the very rich people in the region.
Yes.
And so because the private hospitals, a lot of them who would like to survive slow down, then the quality of health services is bad. So in many private hospitals, having medical doctor is difficult. Many of them they have to deal with only nurse.
Yes.
So
Important question.
yeah, so that's
Yes. No, it certainly is an important question. I think that's the ultimate sort of goal about whether when you enroll some scheme to give access to people, ultimately you want to see whether the quality of the care as well to see whether it's effective or efficient or not. That is an important point. I think what I can say is that the data there's a BPJS or JKN has their own claims data, but so far it hasn't properly captures the quality of the services. We could somehow uses things like whether they get readmitted after 30 days or after a year of treatment, for instance. That's a very common metrics of quality of care that has been used in economics literature, for instance. but we can't really identify the types of hospital in that data, so we don't know whether they're private or not, at least not directly. So it is still an open question, probably. I think it's an important, if there's someone that might have a way to answer that. I think that will be an interesting paper.
Sorry, can I say,
Yes.
isn't Woody's outcome almost inevitable with a tax to GDP ratio of 11%? The government's never going to be able to fund it adequately in a way. That's Woody's point, I think, isn't it? So
Yeah.
that's the question, is with very limited financial means, what is the best system?
Yeah.
I guess. So just follow.
Yeah. So
You don't need to answer, just.
no, yeah, that's something
Sorry.
I will need to slip on it.
Sure.
But that's a good point.
That's kind of a suggestion. If you remember, we did try to assess the efficiency and how hospital respond to this kind of chaotic world of JKN. We use restrict the sample only those who got outpatient care.
Right.
And if there is some kind of rejection in working hours, so at least it's kind of we are guessing if we got outpatient care, do we spend more time not in the office? So probably it's kind of a proxy of the waiting time. So that's what we did in
Yeah.
I don't know if
Yeah.
so it's possible.
Yeah.
It's kind of indication, brother. It's not perfect. But
Yeah, it's not perfect, but if it is gives us some form of indication, that's better than not having nothing. So we'll talk more about it. So.
Questions from online.
Questions from Aryo Irhamna.
Yeah.
The treatment and control groups are defined by household expenditure deciles.
Yeah.
But expenditure is endogenous. It reflects the very choices the paper is trying to measure. Private health insurance premiums are a component of household expenditure recorded in Susenas. A household that drops private insurance reduces its non-food expenditure, which could shift it from the 5 decile into the 4th, moving it from treatment to control. This creates a mechanical negative correlation between PHI or ownership and treatment assignment. Have you assessed whether your results are sensitive to defining deciles based on expenditure net of health insurance premiums, or alternatively using a time invariant proxy for household socioeconomic positions such as asset indices or housing characteristic that does not move with insurance choices?
Thanks for the question. I think my understanding is that that is possible if we just have a cross-section data. But what we're trying to impose here is that if we think that the relative position of the households within the expenditure, and we say that we assume with a greater plausibility that these positions will not change based on some form of strategic, which could happen, and Pak Budi has raised that, and also Mbak has raised that as well, with the whether it's sensitive or not to be account for a control group, then the shock remains plausibly exogenous. So that's one way to think about it, and the way we think about it. But we haven't so far, when we look at different deciles, for instance, and how the impacts on the results didn't change as much. So it's quite robust across different. What we haven't done is that the using different measure to classify the treatment and control group. But I would imagine that even the asset would also be endogenous in some form, right? Not sure. But thanks for the suggestion, and we'll think about it. Yeah, we can do that too. Yeah.
Thanks for the presentation, Giovanni. If I could just make a suggestion or a plea.
Yeah.
There's a tendency in papers like this to have a lot of emphasis on the econometrics.
Right.
And well, some of us are not very good at econometrics, so that turns us off straight away. But more importantly, I think it's really important to remember to think about who your audience is, and to put a lot of effort into explaining the nuts and bolts of what it is you're talking about. Some of us here, a few of the people here obviously have deep knowledge of this system in Indonesia, but a lot of us don't. And so I would like to have been told a whole lot more about how does the bloody thing actually work.
Right.
I think, for example, I think a lot of effort should go into explaining that JKN is providing a very different product to private health insurance. And what are those differences? I'd really like to know about that. The second thing is, I'd really like to know how it works in this sense. In principle, the government is making it possible for everybody to be covered by JKN because it's paying the notional premiums for a very large segment of the population which is poor. Now, if that was actually happening, you would expect an enormous expansion in demand for health services.
Right.
And that doesn't seem to be happening. So what's going on here? I'd like to know more about, do all these poor people, although they're having their premiums paid by the government, are they actually using the system? If not, why not? Probably you've sort of answered this along the way, but not in a way that I have clarity on it.
No, so that's a very that's a very fair point, Parot. I think that there's also where I think about the forum here is that's why I expanded a little bit more on the private health insurance market and how the JKN sort of works. That is not in the paper at this stage. So no, that's fair. But I think we'll try to improve on that next time we do that again. But you're right in the sense that suppose like in the previous sort of like the existing literatures that have looked at the impacts of the JKN, for instance, it's been done quite a while.
Everybody out.
I didn't do nothing on that, but so that it's quite a lot of has been done on that different subgroups and different healthcare different health outcomes as well. But next time when we present, we'll show you a bit more about how the other studies have shown and the overall impacts of the JKN. But in sum, the JKN seems like converging that the demand is increasing and that is consistent. So we have that as well in our paper. But the other papers have also found that once the JKN rolls out, it actually increases the utilization of the healthcare services because, like as you mentioned,
but not amongst the poor people.
Health outcomes don't improve in your story.
Correct. Within that limitation of the variable definition, it is not necessarily improving. But among poor people, that is where the inequality is still a challenge, and it is still an ongoing challenge because even though they have so if you think about like before and after JKN, these poor people pretty much has the insurance in their own pocket, right? So they can access whenever they need to access. But there are studies that and the consensus is that why these poor people is not using as much is because the indirect costs that they have to face when they access the care. So things like transportation costs, the opportunity cost of not doing work at that day, which is still a big barrier in our society, so that explains why only relatively rich people that uses these services. And on top of that, there's also supply side as well that is still an ongoing. So if you think about the major concentration of hospitals is in Java. Even if you need a bypass surgery of a heart surgery, you can only do it in Harapan Kita in Jakarta, for instance. You can't do it in another center. So that is still a big barrier when you think about these indirect costs. So the direct cost is pretty much zero, but those travels, opportunity costs of not doing work, that is what causes why the poor people has not been using healthcare as much.
And all of that should have been utterly predictable. I would say.
Right?
And so if one is interested in redesigning this whole system, sort of take on these things that are fairly obvious.
And
it's the design too.
Yeah, and it's mostly the supply design. It's not entirely the demand design, right? Because you can only do as much with providing free insurance to people. But if there's no work, there's no place to go to. Yeah, and so it's more of a supply or distribution of the supply side that is creating this inequality across areas. Yes, it was.
This is obviously a question, but if you have limited amount of money like to provide, would you rather build or do a lot of hospitals like Harapan Kita and cancer in provincial capital, spend money there to supply?
Right.
Right?
Yeah.
Or improve the JKN system.
Yeah,
right.
Because improving JKN system, for instance, say if you have cancer and you live in somewhere in isolated island, right?
Yeah.
You have to go all the way to Jakarta, you won't be able to use that facility from the JKN anyway.
Yeah.
So if you were Budi, what would you do? I mean, someone there or should be done.
Yeah,
Um,
I think
it's really the key question.
Yeah, I think from an affirmative standpoint, I think and this is my opinion is that you know, building more centers in across areas would likely to be more pro equity rather than less equity, and I think that is something that the JCAN hasn't, I suppose, with this current scheme and this current regime of the health system, is that it hasn't so far been shown that that's the case. So most hospitals that are being built are still concentrated in Java. You still have distribution issues of doctors that want to go in the rural area. So that also some part of relates to the existing infrastructures of that area, like things about, what is the pulling factors of doctors that makes them wants to go there and work there, right? So it's still an ongoing issue, still, I know from pretty much since the nation has been undecided. But I think that is, and I think they have the current ministry has interest in making different centers all across different areas. You can see much more centers being open in not only in Java Island. So that's important. I think that's hopefully if the data allows, we would see more and more people from disadvantaged populations actually using that. But it's something that is actually feasible to empirically investigate using the BJS data sets, for instance, because they have all the data that all the claims, they know who's coming to get treatment and whether they are subsidized or not, where do they live, so they have all this information, but so far it seems like they haven't properly utilized that opportunity.
There's one question from online.
Questions from Pak Yogi Vidyatama.
Yeah.
I am still puzzled with the gatekeeping system.
Yep.
It should take out the inferior normal goods relationship that can explain the drop in the primary care.
Yeah.
So how much gatekeeper activity is being recorded? For example, whether giving referral is being recorded as primary care visit.
Yeah, so that's a good point. But I think the puzzle also I'm puzzled, and everyone in the other co-authors also puzzled with this. We don't know whether that, so it's only coming from the SUSANA, which is essentially asking the individual, the households, if you've used the primary care or if you've visited primary care before, and we don't know what happened in that visit, whether it's only getting the treatment, it's getting the treatment or just getting the referral. But we've seen an overall, whatever it is that the visits occur, it seems like if we think about that as a visit, then it seems like it is decreasing after the JKN rolls out. But I'm not entirely confident that that's the case. So we need to, that's the one of the agenda that we have to keep working on it. Maybe use different data sets to look at, or use IFLS, for instance. I think the IFLS, the Darius Erlangga's study has shown a consistent increase in primary care and also the hospital care as well. So, but yeah, thanks for bringing that up.
Any other questions from the room? I think just additional points, like for me, the reason why you only control province fixed effects, is it because of that supply side, not?
Yes.
District?
Yes. Yes, and we're clustering at that district, so if we control for the district, then we'll wipe out the variation. Yeah.
And just like, depending on where you'd like to publish. So probably you need to engage with the more recent, the ideas, techniques, and even study
Yeah.
methods. So
Yeah.
something to think about. I think, if there are no questions, join me in thanking, Gio and.
Thank you very much. Anyway, looking for the comments and the discussions.
Looking forward to how this paper is shaping up, and good luck to Nia, and then hopefully we'll see you in the next year or 2 years with another paper.
Yes.
So I think with that, yeah, we just close the ISG. Thank you, everyone.
Thank you very much.